Welcome back, guys, and welcome to yet another episode of the Doc Talk. And today we are going to talk about GLP-1 medications, but not from a standpoint that everybody already knows. This horse has been beat to death. We already know it causes weight loss. We are actually going to talk about it in how Dr. Hayi over here, she's going to be answering our questions today, how she, as a family medicine physician, utilizes these medications in her clinic, uh, how she prescribes them to whom, what the criteria are, and the landscape and all that kind of stuff. So, real quick, before we get into that, I will just give you a little refresher about what these drugs are. So, a GLP-1 medication, GLP stands for a glucagon-like peptide. A peptide is just a string of amino acids combined. We have the natural hormone in our gut, the GLP-1 it produces, but in very short bursts. So, what we've done is synthesize this in a lab, which is lasting much longer now, days to weeks, when you inject it, basically. And what it does basically is it slows down the stomach empty. It slows your stomach down so you stay fuller longer. It tells your brain, okay, enough. You're full. And as soon as you start eating, it basically tells the pancreas to start releasing insulin to mop up the glucose that's about to enter your bloodstream, and prevents glucagon from coming out, which is a hormone that releases glucose into the bloodstream. And that is basically, in a nutshell, what is how we've been utilizing it. And there's a lot more interesting research out there coming out about these drugs, which we may get into, or if not, then that'll be a topic of a discussion for a different podcast. So, Dr. Hay, what decisions do you make around describing these GLP-1 medications outside of the obvious, somebody has diabetes? That's what first and foremost these medications are for, is diabetes. What goes through your mind when you sit with a patient?
Yeah, so honestly, I love these medications. I think that they're getting a bad rep in the media, more so for just the way that they've been explained to the media and the examples that we're seeing out there. But the medication itself is a miracle medication in many ways. Okay, um, so for me, I think that most patients, unless they have a contraindication to it, are good candidates for the medication. So a lot of the times, if I have a patient who I know has, suffered from obesity pretty much their entire life, or a patient who is pre-diabetic, or a patient who is developing non-alcoholic liver disease, okay, all of these patients are people that I would bring it up to and say, have you thought about trying a medication for weight loss, or have you thought about trying a medication to help bring those glucose numbers down so that we can prevent diabetes? So I use it more as a preventative medication than anything else.
So, you were talking about the Zepbounds and the Wegovy's, the marketed weight loss versions of these drugs.
Exactly. So Zepbound is the exact same thing as Mounjaro, right? And their scientific name is tirzepatide, okay? And then Wegovy is the exact same thing as Ozempic. So Ozempic and Mounjaro is simply marketed towards the diabetic population, and Wegovy and Zepbound are marketed for obesity. And now a lot more indications that are coming out. For example, Zepbound is now FDA approved for sleep apnea. Okay, so but it's the same drug. It's just branded differently for different diseases.
So it makes sense for people who have diabetes that the medication would be prescribed, covered, all that stuff. What is the criteria for using the weight loss versions of these medications?
hmm So the official guidelines and the FDA approval for obesity for both the medications are that your BMI must be above 30, which puts you in the obese category per the BMI continuum, okay? Or your BMI must be 27 with a comorbidity, okay? A comorbidity is another disease that's being caused as a result of the obesity.
So, okay, that's pretty simple and straightforward. Now, does that capture all essence of population, or
Absolutely not. So I think that that specific guideline is very, very restrictive, because the truth is that there are many, many patients, in my opinion, under the BMI of 27 plus a comorbidity, or under the BMI of 30 without any comorbidities, who are good candidates for the medication. And I think the problem is not so much that a lot of physicians don't believe or not believe in the medication. It's that we have always viewed obesity as more of a person problem as opposed to a disease. you know we see it as a choice. And even though we progress a lot into thinking of it more as a chronic disease and less as a choice, but a lot of us still do. And so a lot of doctors are still under the do absolutely everything under the sun to lose weight, and if you actually cannot do it, then we revert to these medications. And I don't believe that's the correct way of looking at it. Okay.
I would actually agree with you on this concept. During my training, medical school years, I actually tried that a lot. I did the whole, you got to do it, the 150 minutes of weekly moderate intensity exercise, the Mediterranean diet, count your calories, track something, small changes, did all that. Honest to God, I saw no change in year after year after year. In fact, things worsened. Then when I became an attending, now I adopted an opposite approach. I still believe in the foundations. You must do
Mm-hmm.
that. You cannot just give these medications and think it's a miracle drug and we're going to take this and go and have ice cream and pizza and donuts. You
Right.
cannot.
Right.
But I actually utilize these drugs far more earlier
Mm-hmm.
in the disease process than to just keep waiting and waiting.
Exactly. And that's a really good way of putting it, using it earlier in the disease process, right? And we do that with every other disease we look at. So if somebody's hypertensive, you're not going to just leave them with high blood pressure and say, oh, yeah, first go and try all this stuff on your own and then come back to me and I'll give you a medication. If somebody's diabetic, again, same thing. You're not just going to leave them and be like, hey, yeah, come back when it's bad enough, when you've tried everything else. So why do we view obesity that way? Why do we say that you have to, nope, that's not enough. You're not overweight enough yet. Go and become more overweight, and then I'll help you with this. We need to realize that obesity differs so much from person to person. Let's be honest. Two people can eat the exact same thing, do the exact same workouts, and end up with completely different outcomes.
That is correct. Absolutely. Absolutely. So something that's actually, I'm from Pakistan, right? So I'm Pakistani, and so what I know about my heritage is that South Asian men tend to carry a lot more visceral fat. Visceral fat is the fat that's around the organs, so not the outside one, which is actually very dangerous to have. Uh, so the research that I've seen is that for us South Asian men, Indians, Pakistanis, all these people, a BMI above 23 is considered overweight, and a BMI
Mm-hmm.
above 25 is obese.
Right.
So the South Asian men that are living in the United States or Canada, even,
Are
we
really being
don't.
left out.
Yeah, we
Yeah.
don't. There's no way that we qualify. I mean, we should really be qualifying at an earlier time,
Exactly.
not
Exactly.
waiting for the 27 or the 30.
Right. There's multiple trials that show that the risk of diabetes, the risk of heart disease goes up in the South Asian population with a BMI above 23 and 25. Whereas you see that same risk go up in the Caucasian for better, in all honesty, because most research is done on Caucasians, you see it show up after a BMI of 26 or 30, right? So but no insurance is going to cover Ozempic for anybody at the BMI of 23. And quite frankly, most doctors are not going to prescribe it. You see somebody with a BMI of 24 and they don't look, fat to you. So you choose to, you in your bias believe that, okay, because the person has a BMI of 24, they're not overweight, they're not obese, they don't need the medication, right? But the truth is that you have to look at it at a much more patient by patient basis. There are patients who are not good candidates for it even at a BMI of 40, you know and there are patients who are great candidates for it at a BMI of 26. So look at what the effort is that the patient has put in. Look at their ethnicity and what risks they carry that are above the actual stated guidelines. And look at how feasible it is for that patient to actually make the changes that you're asking them to make. Okay. So, for example, I have this patient. She's 41 years old. Okay. She's a single mom. She works two jobs. Okay. Her first job goes from 7 a.m. in the morning to 3 p.m. Okay. Then she goes and she picks her kid up from daycare and she drops the kid off at her mom's house and she goes and does her second shift, which is usually from 5 to 9. Okay. And so she's been talking to me for a while about losing weight, and she struggled to lose just her postpartum weight with the baby. Okay. And then she tries her best, whatever extra time she has, to give it to her child because she has to do that as well, you know? And so the first time that I talked to her and I asked her about exercise, and she tells me all her regular regimen, right? And so she's like, so honestly, when can I exercise? And honestly, the answer is, I don't know. I don't know. When is she supposed to exercise? Are you going to ask her to wake up at 5 a.m. in the morning and put an extra hour in? Sure, in a perfect world, if she's, I don't know, Wonder Woman.
So this is where um, the patient-centered, individualized care falls into place,
Right.
and us as physicians, healthcare providers, understanding that obesity is a disease,
Mm-hmm.
and if the patient is struggling and they just cannot get it done, then let's not let this disease progress into something else,
Yeah, there's no
worsening
shame,
into diabetes, heart
right?
disease, that kind of stuff.
There shouldn't be any shame in using medications for obesity, just like there isn't any shame in using insulin for diabetes, right? We should be putting it out. We should understand as physicians what the risks are of letting the disease progress. And instead of seeing it as a shameful event for the patient or for us that we're using the medication as a crux, we should realize that we're simply treating a disease. And as with any disease, if a person has more risk factors, right, you treat them more quickly. So for example, if someone's dad had colon cancer at 35, you're not going to wait for them to turn 45 before you do a colonoscopy, right? So with obesity, lifestyle, socioeconomic status, the amount of time you have, what you do at home, all those things are actually risk factors, right? So being from a lower socioeconomic status is a risk factor for obesity. And so you should be treating those patients differently than you're treating somebody who maybe has a personal trainer.
Okay. Well, thank you for providing your input. That was very insightful, actually. Uh, Hopefully for our viewers and listeners. That's basically how what goes on in our heads when we're deciding to prescribe or not prescribe these medications. And of course, the biggest barrier always ends up being the insurance company. We also must keep that in mind.
Mm-hmm.
Um, but yeah, stay tuned for more future episodes. Where we'll unpack even more insights into GLP-1 medications and other stuff.
Yeah. And if you guys have recommendations for things that you'd like to hear us talk about, feel free to drop a comment and let us know.
All right, take care.